Good day, and welcome to today's discussion session on burns. Burns is quite a large and interesting topic, so I would indulge your patience and try as much as you can to get one or little um, points from this discussion session. So enjoy. Outline for our discussion includes introduction, epidemiology, classification based on etiology, based on depth, based on severity, then pathophysiology, pathology, then the management, then complications and conclusion. Burns can be defined as the coagulative or liquefactive necrosis of the skin and underlying tissues due to exposure to extremes of temperature. So in this definition here, the points here are coagulative or liquefactive necrosis of the skin and the underlying tissues due to exposure to extremes of temperature, which could be either hot or cold. So I think the definition is simply it's simple to remember. So it's a coagulative or liquefactive necrosis of the skin and underlying tissues due to exposure to extremes of temperature, which could either be hot or cold. Now, necrosis is simply tissue death following ischemia. Ischemia is impairment or loss of blood supply to a particular organ. So following ischemia, you have tissue death, and different tissues exhibit different forms of necrosis. So we have coagulative necrosis. In coagulative necrosis, the form of necrosis in which the injury denatures structural proteins and enzymes, and because structural proteins and enzymes have been destroyed or denatured, it blocks proteolysis of the dead cell, that is digestion of the dead cell. So the dead cell is not digested, and so the affected tissue exhibits a firm texture. So what you see is a firm texture because the dead cell is not digested, and this occurs in all organs except the brain. So all organs experience or rather undergo coagulative necrosis except the brain. Now in liquefactive necrosis, even as the word implies liquefactive, it gets liquefied, something like that. So there's digestion of the cells here. So it means the enzymes and the proteins are not injured or are not denatured, so they are still present to undergo digestion of the cells or the dead cells. And then this digestion of dead cells results in transformation of the tissue to a liquid viscous mass, which could be seen as pus. This type is the type seen in hypoxic deaths of brain tissues. So brain tissues undergo liquefactive necrosis, and also in burns caused by alkalis. Epidemiology. The majority of burns in children are scalds. Scald burns really are burns following exposure to hot liquids, and it's most common in children. So scald burns are the type of burns most common in children. You can figure out a reason why, because most times children want to explore and they are not sure of what they are touching, so you could have splash of hot liquids on their body. Then among adolescent patients, the burns are usually caused by young males experimenting with matches or flammable liquids. So you can as well say that chemical burns and flame burns are common. Chemical burns, flame burns are common among the adolescent age groups. Then adults, scalds are uncommon but are less frequent than flame burns. So in adults, flame burns are much more frequent. Flame burns are those burns that cause following exposure to flames from either a burning house, a burning bush, or cooking gas or kerosene stove. Then most electrical burns and chemical burns occur in adults. Cold and radiation are very rare causes of burns, and then also in adults. Mental diseases, epilepsy, alcohol, drug abuse usually are underlying factors in as many as 80% of patients with burns. So you can say that in more than 80% of patients, adult patients, there's usually an underlying condition for burns to occur, usually maybe epilepsy or alcohol or drug abuse. A person who is drunk is more likely to get burns because he's not in his right senses, and then a patient with mental disease as well. Or it could be attempted suicide or assault. So classification of bonds. We classify bonds based on etiology, based on depth, and then based on severity. So based on etiology, we have flame bonds. Flame bonds are bonds that occurred following exposure to flames. Flames are defined as superoxidized air, and you can get flame bombs from burning bushes, burning houses, your kerosene stove, your cooking gas. So those are causes of flame burns. Then we have scald. Scalds occur due to exposure to hot liquids, and remember we said they are common in children. Then we have electrical burns from electrocution. We have chemical burns, which could either be acid burns or alkali. Acids usually will cause a coagulative necrosis. So acid will cause a coagulative necrosis. While alkalis will cause a liquefactive necrosis. So you can use this to remember. Acid, that's the C in acid, can stand for the coagulative necrosis here, while alkalis, the L in alkalis can stand for the liquefactive necrosis. Okay, now you have contact bonds. Contact bonds occur following contact with hot objects, maybe like hot iron. Then we have inhalational injury. Inhalational injury has a definition. The definition is aseptic laryngotracheal bronchitis due to exposure to products of incomplete combustion in an enclosed space. Now, laryngotracheal bronchitis simply means an inflammation of the larynx, the trachea, and the bronchioles. Now, if you can remember, we've heard something like laryngotracheal bronchitis somewhere. Yeah, you remember pediatrics, crew. Now, in that case, the laryngotracheal bronchitis there is a septic one because it's caused by invasion by an organism. There's an organism present that is causing the inflammation. But in this case, it is aseptic. There is no organism in bones. It is just the exposure to these incomplete products of combustion, which could be the smoke, the gases, and all that causes this inhalational injury. And it occurs commonly in an enclosed space because in an enclosed space, you're more likely to inhale these gases more. Then we have radiation injuries. Now, based on depth, there are two classifications. We have the British classification and then we have the American classification. So first, we have superficial burns. Superficial burns are those burns that affect only the epidermis. So only the epidermis is affected in superficial burns, and it's also described as first degree burns. So superficial burns affect only the epidermis and is described as first degree burns, while superficial partial thickness burns now affects the dermis, but now it's just the papillary dermis that is affected. That's the upper part of the dermis that is affected, and that is the second degree burns. Next is the deep dermal burns. Deep dermal burns, now it goes further down, so you have the involvement of the reticular dermis, which is the lower part of the dermis. That's deep dermal burns, and it's the third degree burns. Then when the entire thickness of the epidermis and the dermis now is affected, is called full thickness burns, and that is described as the fourth degree burn. It's important for us to understand this classification because it will help us in management of patients. So superficial burns just affect the epidermis, and there are ways to recognize the different types of burns. We'll talk about that subsequently. Superficial burns just affects the epidermis of the skin, well, superficial partial thickness and deep dermal burns, they affect the dermis, but Superficial partial thickness bones affects the upper dermis, that's the papillary dermis, while the deep dermal bones goes deeper, affecting the reticular dermis, while foot thickness affects the entire length of the epidermis and the dermis. And that gives us the first degree, the second degree, the third degree, and the fourth degree. Now, superficial bones. Only the epidermis is affected, as we earlier said. Only the epidermis is affected. In this case, there is no coagulative or liquefactive necrosis. What we have here is just redness, erythema, non-blanching erythema. All you have is just that you see the skin red. You may not see that redness typically in blacks, but in fair-skinned individuals, you see that redness following superficial bones. This type of bone usually is not considered when calculating fluid requirements for patients. And if a patient just has only superficial bones, you wouldn't even admit the patient in the hospital. But if the patient has other forms of bones as well as superficial bones is not considered when you are calculating the fluid requirement for such patients. Now we have superficial partial thickness bones. Here, the epidermis is affected, and then just not the epidermis, part of the dermis is affected. The upper part of the dermis is affected, which is called the papillary dermis. They are usually very painful. Because the nerve endings are not burnt off. Nerve endings are still very much intact. They are there, so the patient will feel pain, so much pain. And then you have blister formation as well. So when you see blisters, you most likely think of a superficial partial thickness bones. Usually the blisters form following elevation of the epidermis over the dermis, and so fluid accumulates in that space. Now the underlying dermis is pink and moist, and so in the case where the blister has already been ruptured, the wound appears like this, as seen in this diagram. The wound appears like this, and it is described as a weeping wound. It weeps because lots of fluids and exudates come out from this wound. So the wound is described as a weeping wound, and the capillary return is clearly visible when blanched. So when you try to do a capillary return on that area of the skin, it comes, and then when you remove your hand on application when you remove the pressure applied, it goes back. So there's no capillary stain. That when you apply pressure, it doesn't just remain red even after removal of the pressure. That there is no fixed capillary stain. And then pinprick sensation is normal. So the sensations are still very normal. Superficial partial thickness bones heal without residual scarring in 2 weeks. Now, deep dermal bones. In deep dermal bones, we said it goes deeper, involving the reticular dermis. It goes deeper to involve the reticular dermis. The pain is not as severe because some of the nerve endings might be burnt off in deep dermal bones, and then a mottled appearance is seen. Mottled appearance is a reddish purplish like appearance, and it's also marble like a marble, as seen in this diagram here. Clinically, the epidermis is lost, so the epidermis is completely lost. The exposed dermis is not as moist as in superficial bones. So unlike the superficial partial thickness bones that we said usually weeps with lots of fluid and exudate seen on the wound, you don't see that. You don't see as much weeping in deep dermal bones. There is often abundant fixed capillary fill. So when you put applied pressure, the area just appears red. Even on removal of the pressure, it remains very red. Sensation is reduced, and the patient is unable to distinguish sharp from blunt pressure. So it means that the nerves are really much affected here, so sensation is reduced and there's pain but not as severe. Deep dermal burns take 3 or more weeks to heal without surgery, and usually they may lead to hypertrophic scarring following healing. Now for foot thickness burns, the epidermis and entire dermis are affected. So the epidermis, the entire dermis are affected. As you can see in this picture, it goes down from the dermis to the epidermis, and even there could be affectation of the subcutaneous tissue. Patient usually feels no pain. There's anesthesia, no pain, because the nerve endings have been burnt off. There are no nerves to transmit the sensation of pain. So a needle can be stuck deep into the dermis and the patient will not even feel pain, or there will be no bleeding. So these are the kind of patients you see in the A&E, and they are just quiet. Even with the severity of the burns, they don't feel pain, they are just quiet. Now, clinically, they have a hard leathery feel. The appearance can vary from that similar to the patient's normal skin to charred black. So the appearance can be like patient's normal skin, but yet it's dead, to a charred black. So it can appear that the patient's normal skin, or it can appear black, charred black, depending upon the intensity of the heat. There is usually no capillary return. And then scars, which are dead tissue, tend to form. So following full thickness bones. So scars are like the dead hard tissue. They usually tend to form following full thickness bones. And remember we say that most part of the body exhibit coagulative necrosis, so they are usually hard in texture. So scars are like hard bones that form following full thickness bones, and then when they occur circumferentially around the limb, they are hard and they occur along the entire circle. For example, this whole limb is burnt, and it's burnt all around. And it's burnt all around because it's hard. It could form like a compression around the limb and lead to compartment syndrome. So in that case, you would have to relieve the compartment syndrome by making an incision. Usually a fasciotomy may be done to release the compartment syndrome, to release the pressure rather. Okay, in summary, we said we have superficial bones, superficial partial thickness bones, deep dermal bones, and full thickness bones. For superficial bones, we said it affects just the epidermis. I hope you remember that. Epidermis for superficial bones. And we say there's non-blanching erythema with redness. So once you just see the redness and it's very painful, but it's really not affected. The epithelial lining is still intact. You think of superficial bones. And for superficial partial thickness bones, they are blisters. And if the blisters have already ruptured, the wound weeps. There's lots of moisture on the wound, and there's severe pain. And then for deep dermal bones, there's mottling. The wound appears red purplish with and it's marble-like, and does not weep. It's not as moist as superficial partial thickness bones, and then there's moderate pain and sensation is reduced. But for full thickness bones, there's charring. There is no pain because the nerve endings have been completely burnt off. Now, this classification based on severity. We just talked about based on depth. We've talked about based on etiology before, where we said flame bones, scarred, and all. And then we talked about based on depth. Now we're talking about based on severity. Please, I hope you follow. Okay. Based on severity, we have major bones, and then we have minor bones. Now, what are major bones? Inhalational injuries are major burns. Chemical burns, irrespective of the total burn surface area. TBSA means total burn surface area. So chemical burns, irrespective of the TBSA, are major burns. Electrical burns are major burns. Burns involving head and neck are major burns, because if there is burns involving the head and neck, you will most likely suspect an inhalational injury. Burns involving the axilla are major burns. Burns on the flexor surfaces, such as the elbow, the knee, the hip areas, they are major bonds. Bonds involving the perineum, although it's just 1%, is a major bond. Bonds occurring extreme of age, that's in children and then in the elderly, are major bonds. Bonds in patients with comorbidities such as psychiatric patients, asthmatic patients, epileptic patients, they are major bonds. Bonds, okay, now based on total bond surface area, which is one of the very important ways of classifying major from minor bonds. You have, so when you do an estimation of the total bond surface area for superficial partial thickness bonds, if you make an estimation of 20 or greater than in adults, 20 or greater than adult is a major bond, and then half of it, which is 10%, when you make an estimation of greater than or equal to 10% in children, it's a major bond. So I want us to remember this easily. Superficial partial thickness bonds, if you look at the patient and then you make an estimation of 20% or more using the Wallace rule of 9, we'll talk about it much later, using the Wallace rule of 9, and then you estimate 20% in adults, you have to admit that patient. Half of it is 10. If you estimate 10% in children, you have to admit that child. Now for foot thickness bonds is more severe than superficial partial thickness bonds. So when you make an estimation of just 10% in adult, you have to admit that patient. And half of it, which is 5, you make an estimation of 5% of foot thickness bonds in children, you have to admit that child. Now, patients with major bonds are usually kept on admission. So it means all the criteria we just outlisted for major bonds are all indications for admission in bonds. So all of those things we just mentioned are indications for admission in bonds. And then every other kind of bond that does not fit into the category of major bonds is a minor bond. So always remember that every other kind of bond that does not fit into the category of major bonds is a minor bond. So pathophysiology. So briefly, we talk about the pathophysiology to help us to understand why bonds is as severe as it is. So bonds cause damage in a number of different ways, but by far most commonly affected is the skin. So the skin is the organ commonly affected, because the skin is the protective covering of the body, and so once it's burnt off, it means that the body is exposed to a whole lot of things. Fluids in the body gets to easily evaporate because the skin, which is the protective covering of the body, is lost. Burns can also cause damage to the airway and lungs, causing life-threatening consequences. Other systems affected are the circulatory system, gastrointestinal system, the immune system as well. So the airway injuries occur when the face and neck are burnt. So when you have burns to the face and neck, you should suspect airway injuries. And then if a patient tells you he was trapped in a burning vehicle, a burning house, a car, an aeroplane, and is forced to inhale hot and poisonous gases, you should also suspect respiratory system injury. So burns occurring in an enclosed environment would most likely cause respiratory system injuries. And then these inhaled hot gases, they can cause supraglottic airway burns and laryngeal edema. The inhaled steam will go further down to cause subglottic burns and loss of respiratory epithelium. So I think you should take note of these the different causes, the different consequences that could occur. Hot gases will cause supraglottic airway burns, while inhaled steam will go further down to cause subglottic burns. And then inhaled smoke particles, because they are so little, they will go further down to cause further down the respiratory tract to cause chemical alveolitis and respiratory failure. Inhaled poison such as carbon monoxide, which has a very high affinity for hemoglobin, about 250 times more than oxygen for hemoglobin, can cause metabolic poisoning when inhaled. And then foot thickness bones, as we said before, foot thickness bones usually are associated with eschar formation, and with eschar formation it can cause mechanical blockage to the rib movement, because eschars are hard, and the hard nature would limit rib movement, and it can cause a mechanical blockage and eventually respiratory obstruction. So inflammatory and circulatory changes that occur. Bones produce an inflammatory reaction, and this leads to vastly increased vascular permeability. So there's increased vascular permeability following inflammation, and then water, solutes, and proteins move from the intravascular to the extravascular space. The volume of fluid loss is directly proportional to the area of the bone. So you have to remember that the volume of fluid loss is directly proportional to the area of the bone. About 50% of surface area. So when you have a loss of about 50% of surface area, the loss of fluid produces shock. So for the GI tract, the inflammatory stimulus and shock can cause microvascular damage and ischemia to the gut mucosa. So when there is, following the inflammation and then the shock, there is in shock, the blood supply is shunted to the more important organs, and so there's ischemia to the gut mucosa. And then also there could be reduced gut. This can lead to reduced gut motility and prevent absorption of food. Now, failure of enteral feeding in a patient with a large bone is a life-threatening complication. If you have seen a video on surgical nutrition, I'm sure you would easily understand this. Enteral nutrition is important to keep the gut wall mucosa intact. So when there is failure of enteral nutrition, when enteral nutrition is not instituted in the patient, the gut wall mucosa tends to undergo ischemia, and then it sloughs off, leading to loss of integrity of that gut mucosa. And so those gut flora, those gut bacteria easily translocate into the system through the vessels on the GI tract. So they translocate into the system and become an important source of infection in bones. So it is very, very important that in bones you must institute enteral feeding as soon as you can to prevent these sepsis that could occur. Gut mucosa swelling, gastric stasis, peritoneal edema can also cause abdominal compartment syndrome, which can splint the diaphragm and increase airway pressure needed for respiration. So abdominal compartment syndrome can occur too following bones. And then the renal system, following loss of fluid, reduced intravascular volume, there will be reduced glomerular filtration rates that may progress to acute tubular necrosis, oliguria, anuria, and renal failure. And then deep bones with tissue destruction can lead to hemoglobinuria or myoglobinuria that would eventually damage the distal convoluted tubules. In the immune system, inflammatory changes caused by bones can have an effect on the patient's immune system. Cell-mediated immunity is significantly reduced in large bones, leaving them more susceptible to bacterial and fungal infections. So it's very important that you give antibiotics to patients with bones. There are many potential sources of infection, especially from bone wounds. So you can have infection from the bone wound, from the lung if it's injured, from the central venous line if you are giving if you are giving parenteral feeding, from the cannula site as well, from tracheostomy, from urinary catheter if present. So all these are potential sources of infection. So there has to be antibiotic prophylaxis, or if there is infection already established, you have to give antibiotics as therapeutic antibiotics. And the pathology, so we just talked about the pathophysiology. So you've seen the systems that are affected in bones and how important it is. Extent of injury depends on the temperature, that's the temperature, duration, resilience of the tissue affected. Local effect of tissue injury is described by the Jacksonian model of histopathological zones. So we have the Jacksonian model of histopathological zones. So it's important to remember the Jacksonian model of histopathological zones. Now we have the zone of necrosis, which is the center, and here there is irreversible damage. The next zone is the zone of stasis or ischemia. Here there is ischemia, and it can progress to necrosis it can progress to necrosis by ischemia infection, or it can be reversed with adequate resuscitation. Now the outermost zone is the zone of hyperemia with features of inflammation, and is expected to resolve completely in 7 to 10 days. So it's just like this. So you have the outermost zone, which is the zone of hyperemia. You have the middle zone, which is the ischemic zone. Then you have the innermost zone, which is the zone of necrosis. In this innermost zone now has undergone necrosis, so there's irreversible damage. Now the middle zone now is the zone of ischemia, and this is the zone you are trying so much to rescue, because with adequate resuscitation you can rescue the zone. Now this is the outermost zone of hyperemia with features of inflammation that would resolve on its own naturally within 7 to 10 days. Now management. The principles of management can be summarized into to revive, to restore, to repair, and rehabilitate. That's the 4 R's. 4 R's. To revive. So we have the four R's, which is to revive, to restore, to repair, and to rehabilitate. And this 11-point outline clearly expands on what these 4 R's are trying to tell us. So we have reviving. You want to revive the patient. Restore, you want to restore what has been lost. So you want to also repair where in cases where you can repair, and then you want to rehabilitate the patient. So first, on our number 1 is to institution of adequate airway and breathing, because you know that if there is airway injury, that would kill the patient first. The consequences of airway injury will kill the patient first because of laryngeal edema, and then airway obstruction to airway, obstruction to the airway, and then hypoxia following, that will eventually follow. Then you have adequate fluid resuscitation, which is very, very, very key in management of burns, fluid resuscitation and maintenance. Then you have the local wound care, so the wound that has been sustained, care of that wound and the cover, whether in form of primary healing, or if you want to use grafting. Then correction of electrolyte derangement, nutritional assessment and support, which is also a very important point in management of burns. The adequate analgesia, so you want to give patient adequate analgesia for pain. It's very, very important for pain. Then you prevent and treat any form of infection that may be present. In deep vein thrombosis prophylaxis, because patients will stay in bed for long and you want to prevent deep vein thrombosis from occurring. Then antipyretic agents, because as the bone wound heals, histamines are produced that would cause itching, so you want to give antipyretic agent. Then you can correct any cosmetic concerns that may be present. Then you rehabilitate the patient. So this is just a summary of what we'll be talking about. Now, in management of burns, we have the pre-hospital management, we have the hospital management. The pre-hospital management usually occurs at the site of the burn accident before the patient is brought to the hospital. So usually there are medical services that are rendered to burns patients before they are brought to the hospital, and the care can be summarized under MIST. So you want to know the mechanism of injury, that's you identify the cause of the burn, you ensure rescuer safety, you stop the burning process if you can, and then you check for injuries sustained. You check, ask for signs and symptoms, especially if you suspect carbon monoxide poisoning, or if you are suspecting airway injury. Then you institute certain form of treatment, such as cooling the burn wound, So cooling should occur for a minimum of 10 minutes and is effective up to 1 hour after the burn injury. You give oxygen where necessary, and then you elevate the burnt parts. So this is the summary of pre-hospital care. Missed. M is for mechanism of injury. So you just want to know everything about the injury. You identify the cause of the burn. Okay, you stop the burning process. You ensure rescue safety, and then injury sustained. You want to check for injury sustained. You ask for symptoms and signs, and then the emergency treatment you can institute before you get to the hospital, such as giving oxygen, cooling the burn wound, elevating the limb where necessary. Now for hospital management of acute burn injury are the same as any acute trauma case, following the ATLS protocol. ATLS means Advanced Trauma Life Support. So you're following ATLS protocol, which includes the primary survey, the secondary survey, and the tertiary survey. For the primary survey, it involves resuscitation to identify life-threatening complications and prevent it. So primary survey is that you want to resuscitate the patient to prevent life-threatening complications. So you want to identify life-threatening complications and then prevent it. That is the aim of primary survey. So it's summarized under ABCDE of resuscitation, where you have airway control. B is for breathing and ventilation. But in this case, since we're talking about burns, under B we do a burn wound estimation. Then C for circulation and fluid resuscitation. D is for disability, that's you check for the neurological status, and then you also do an orthopedic assessment and you administer drugs here. Then exposure to environment, especially E is for exposure and environmental control. Then F is for fluid control, monitoring input and output. Then others is the local wound management. That's the burn wound management. So for the airway, the burn airway creates symptoms like swelling usually, and if not managed proactively, can completely occlude the airway. So usually the symptoms that a burnt airway will create is swelling, and if you don't manage that swelling proactively, it would completely occlude the upper airway. So whenever you suspect airway injury, so the key is whenever you suspect airway injury, and how do you suspect airway injury? When there is burn to the face, head and neck, when there's a history of burns in an enclosed space, you suspect it, and then you do an early intubation of the suspected airway burn. And the time frame from burn to airway occlusion usually 4 to 24 hours. So you have like a golden hour of 20. The treatment is to secure the airway with an endotracheal tube. So you pass on the tracheal tube quickly, and then until the airway has subsided, usually, which is 48 hours. So you pass the tracheal tube and leave it in situ till the swelling has subsided, and usually this takes about 48 hours. The symptoms of laryngeal edema, such as change in voice, stridor, anxiety, respiratory difficulty, are very late symptoms. So when you have these symptoms already setting in, you already know that airway obstruction is already imminent, and intubation at this point is often very difficult and impossible because of the swelling which has already occurred. So in that case, you want to probably do a tracheostomy. So acute cricothyroidotomy equipment must be at hand. So you have to have the equipment to do emergency tracheostomy at hand when you are intubating a patient with delayed diagnosis of airway burn. So breathing. The clinical features are a progressive increase in respiratory effort and rates, rising pulse, anxiety, confusion, and decreasing oxygen saturation. So when the breathing is affected, the way you suspect is when the respiratory rate is increasing, when you check the SpO2, it's reduced. When there's probably anxiety and confusion, when there's rising pulse. These symptoms may not be apparent immediately, especially when you have carbon monoxide poisoning. It can take up to 24 hours to 5 days to develop, and treatment starts as soon as this injury is suspected and the airway is secure. Physiotherapy, nebulizers, and warm humidified oxygen are useful. Patient's progress should be monitored using respiratory rate. So you monitor this patient using respiratory rate and measurement of blood gases. The key, therefore, in the management of inhalational injury is to suspect it from the history. It's very important, though. So suspect it from the history means your history is very important. Even if the patient cannot tell you, there should be stand bias. So he asked those that were the onlookers. So it's important to take note of this, that management of inhalational injury is to suspect it from the history and then institute early management and observe carefully for deterioration. If you don't take any other thing from airway and breathing, you must take this last point, which is that management of inhalational injuries for you to suspect it from the history. So once you start suspecting it, institute early management. So for bone wound size estimation, so you said B is for both breathing and bone wound size estimation. So you want to do to estimate the bone wound size, you would do a bone surface area. You estimate using the area and then using the depth. For estimation using bone surface area, you can use the palm. The palm is described to be 1%, so you can use the palm to estimate. Then you can use the Wallace rule of 9, which is rapid but not very accurate. Then there's the Lund and Browder chart, which is very comprehensive. It's most accurate if used correctly, and it compensates for variation of body shape with age. So these are the ways of estimating bone surface area. So look at the Wallace rule of 9 now. Head and neck is 9. Both upper limbs are 9. The anterior trunk is 18%. The back is 18%. The perineum is 1. Then both lower limbs are 18. I think it's easy to remember. Head and neck is 9. Both upper limbs are 9. So when you use your hands to touch your head, so your head and your hands are 9, 9, 9. Your legs are quite big. They're bigger than your hands, obviously. So you have 18, 18. Then your anterior trunk is 18. Your posterior part, that's your back, is 18. And then the perineum is 18 as well. So both lower limbs 18. Perineum is 1%. Perineum is 1%. The upper limbs 9%. Alongside with the head and neck 9%. So the anterior, that's the front, anterior trunk is 18%, and the back is 18%. Now, to estimate using the depth of the bone, that's to estimate the bone size estimation, you can use the depth of the bone. Here you have, we've already talked about these degrees before, so I'm sure you can easily flow with this slide. So we said first degree bones is the superficial bones, where the epidermis, just the epidermis, is affected, and it is it's red, it's erythematous, it's painful and very red. That's how you recognize it. Then we said second degree, which is superficial partial thickness bone. Here the injury extends to the papillary dermis. It's painful, erythematous with blisters. I'm sure you already know this because we've discussed this extensively in previous slides. So you can see here the partial thickness, there's a blister here. So you can see it's a blister here, and it's very, very painful. Now when you go deeper, you have the deep dermal bones deeper, and then the fourth degree, which is the full thickness, which is the entire length here has been lost, and it's usually it could be painless, it's black and leathery with a hard scar. So that's the depth of the bones. Remember, I said if you calculate and then you get 20% of superficial partial thickness, it's a major bones in adults. I'm sure you remember that. And then half of which is 10% is a major bones in children. But for full thickness, if you get 10% in adults, you have to admit. If you get half of it, 5% in children, you have to admit. So you can actually estimate the depth of a bone when you know the course of the bone. So it's pretty easy, because so if your history is suggestive of scarred, that's hot water bone, you most likely think of a superficial bone, superficial partial thickness bone, but with deep dermal patches, and usually to be in a young infant. So in is that scarred. Remember, we said scarred is from hot liquid. So it could be superficial. It could be superficial partial thickness. It could just be like a blister, but there may be some deep dermal patches as well. And then fat bones, usually deep dermal bones. Then flame bones. In flame bones, you could have deep dermal and full thickness bones usually. So flame bones goes deeper. The alkali, including cement, usually goes deep, because alkali cause liquefactive necrosis, so they tend to keep digesting down. So you have deep dermal or full thickness bones. Acids usually cause coagulative necrosis. So when they just cause coagulation, it tends not to go deeper, because the coagulative substance formed would prevent the acids from going deeper to destroy deeper structures. So usually you could have superficial partial thickness bones with weak concentrations. Strong concentrations usually cause deep dermal bones. Then electrical contact bone causes full thickness bones usually. So now we're in C. So we've talked about the A, the B. We had two B's. That's the breathing and then the bone wound size estimation. And now C, which is circulation of fluid resuscitation, and it is very, very important in our resuscitation of bone patient. So quickly, a white ball cannula is passed, usually 16G cannula. Blood is collected for Paxil volume, grouping across matching, serum electrolyte, urea and creatinine, and then you give fluids. You can either give crystalloids or colloids, but colloids are much more preferred. But initially, it's good to give crystalloids, because they initially help to expand the already collapsed vessels. But colloids are much more preferred, and there are various formulae used in calculating resuscitation fluid requirements. But commonly used in most facilities is the Parkland's formula. Now, in the case where you want to use crystalloids, Ringer's lactate. Ringer's lactate is preferred. Then you pass a urinary catheter as well to monitor urinary output, which is very, very important, because you may suspect acute pleural necrosis in this patient because of reduced glomerular filtration rate, and there may also be myoglobinuria, which can destroy the glomerulus. So you should monitor urinary output. It is very, very important in this patient with bones. Now this is Parkland's formula. It's simple, very, very simple. This is just it here. So 4 ml times the weight, or rather just say 4 times weight times total bone surface area. Simple. 4 times weight times total bone surface area. So in an emergency situation, when you don't want to do the elaborate Wallace rule of 9 estimation, you can just do an eyeballing method to estimate total bone surface area. So you can calculate the fluid and start resuscitation. Now, the maximum total bone surface area that can be used in calculating is 50%. It is very, very important that we remember this. So even if you calculate for this patient and then you get 60% as the total bone surface area, you must use 50%. You shouldn't estimate, you shouldn't go beyond 50% when you are calculating for using the Parkland's formula. Now, the total volume calculated is given over 24 hours and it is divided into two. So once you've done this calculation, let's say the patient, there's a patient that comes, the patient weighs maybe 50 kilogram, and then the total bone surface area is 50. You calculate. Once you calculate 4 times 50 times total bone surface area of 50, the amount you get, you divide it. The first half is given over 8 hours from the time of bones. So you give the first half of the fluid over 8 hours from the time of bones, and then the second half you give over 16 hours. That's the remaining 16 hours. So the total is 24 hours. So when you divide the total volume of the fluid you have gotten after calculating using your Parkland's formula, you divide it. The first half you give it 8 hours, calculating from the time of bones. Then the second half you give over the remaining 16 hours. So if the patient was brought to the hospital like 2 hours after the bones incident, so it means that you remove that 2 hours from that 8 and then you get 6 hours. So it means that the first half of the resuscitation fluid will be given over 6 hours for this patient. I hope you understand. So even if patient comes 3 hours after the time of bones, you minus 3 from 8 and then you give over the remaining hours, which will be 5 hours in that case. Now, D for disability and drugs. So you do a neurological assessment, especially if you suspect carbon monoxide poisoning, and then you do an orthopedic assessment if you to check if there are any fractures. Then drugs will be administered. You can give analgesics for pain, anti-ulcers, because bones can cause chronic ulcers, so you give anti-ulcers. Then tetanus prophylaxis is also given, and antibiotics for infection. Environment and temperature control. The temperature should be controlled in this patient to prevent hypothermia, which is a major killer in bones. Then fluid and electrolyte control, input and output monitoring. So you ensure that the patient gets adequate fluid. So you verify your fluid resuscitation. So you continue with your maintenance fluids. You correct any electrolyte derangement that may be present, and then you monitor urinary output and vital signs. And then our local wound care. So we're still under the ABCD of primary survey. Now we are in others. That's the local wound care, which is the primary, which is like the the primary result of the bone. So you go, if the different types of bones have various ways of management. For superficial bones, usually no treatment is required. For superficial bones, no treatment is required. Usually heals following application of maybe cold running water on the site of the bones, and then you can give analgesics for pain if the pain is really severe. That's for superficial bones. Remember, in superficial bones, the epithelial lining is still intact. There are no blisters. It's just redness. So you just put the wound under running. You just place the affected part under cold running water. And for superficial partial thickness bones, if the blisters are intact, there are different schools of thought about intact blisters. You could leave them alone and then it will heal from beneath. Some other schools of thought have the opinion that the blisters could be debrided and then you apply dressing. But either ways, they both have good outcome. Where blisters already come ruptured, you usually have to apply a dressing, which could either be open or closed. But it's important that the dressing is done aseptically. And the dressing agents used, you could use demazine cream, povidone iodine soaked in gauze, or sulfur-2 as the agents for dressing. So you place them on the layer where they are required in the layers of wound dressing. So the sulfur 2 is usually placed on the non-contact layer, that's the first layer. Then you can use your povidone iodine at on the antibiotic layer or the capillary layer. I'm sure we remember layers of wound dressing, so that's what I'm just saying. I assume you know the layers of wound dressing. So these are the agents that are used in dressing superficial partial thickness bones. As I said, it could be either open or closed. So you could just apply the sulfur tool and then place a gauze on it, or you could close using the crepe bandage after applying all the layers. And for deep dermal and full thickness bones, usually the bones area is debrided and grafted. So you usually have to excise the bones area and then you graft. Grafting can be done either immediately or it could be delayed. So it can be done immediately or you could delay it to allow for some formation of granulation tissue before you graft. Deep dermal bones may be managed conservatively with dressing, just like superficial partial thickness bones, depending on the person managing the bones. And then when eschars are present in especially in full thickness bones, usually escarotomy is done. So escarotomy is just a process of removing the eschars. It's a specialized process of removing those eschars. So just to recap, superficial bones, no treatment. So you just place under running water and then it will heal. It will heal normally on its own. Superficial partial thickness bones, usually if the blisters are already ruptured, you would have to dress. You have to dress aseptically. You clean the wound with maybe normal saline. You clean the wound and then you dress the wound. Then for deep dermal full thickness bones, you debride the bones part and then you graft, which can be done immediately or delayed. Where eschars are present, you do an escarotomy. And for secondary survey, you do a more detailed history, detailed examination, investigation, and then other treatment could be instituted for the patient. So in the history, so this is more like for if you meet a patient and then you want to take a history now, a more detailed history after your primary survey, after you resuscitated the patient and you want to know exactly what happened. You would want to, it could still be summarized under MIST, that's MIST. You could still take your history in that way. It's just to help remember. So M, mechanism of the injury. So if you just think about anything related to the injury, so you want to know the type of bones. Is it a flame bone? Is it scarred? That you want to know what caused the bone now. Is it flame? Is it scarred? Is it hot water? Is it electrical? Is it a chemical? Now you want to know how it happened. Were you cooking? And you want to know where it happened. Was it in an enclosed space? You want to know if it's in a house, if it's in a car. If it's in an enclosed space, you don't know how many doors are in. So you want to know how ventilated the place is. Then you want to know the type of clothes the patient was wearing. Usually nylon clothes tends to burn faster, burn more than cotton clothes. Then you want to know if the place was smoky because of inhalational injury. And you want to know how the patient escaped as well. Then you want to know injuries sustained, which parts were injured. If there's injury to the face, head and neck, you suspect airway injury. Then ascertaining the parts of the other parts of the body that are affected. Then ask for that symptoms and signs, and you can go systematically. So in the CNS, because you were suspecting carbon monoxide poisoning, you ask for headaches, disorientation, coma. Then the respiratory system, ask for stridor, change in voice, dyspnea, production. Okay, if there's cough that is productive of carbonaceous sputum, you suspect an inhalational injury. Then GIT, you want to ask for epigastric pain to rule out Collins ulcer. Then the renal, you want to ask of urinary output to rule out acute renal failure in this patient. And then the T will be for treatment so far. What the patient did before coming to the hospital, because in our typical African setting, some patients may apply certain substances on the wound that may lead to infection of the bone wound before coming to the hospital. So you want to know the treatment so far as well. So that's for the history. So for examination, you would want to do a more a more detailed examination now. So now you want to use the Wallace's rule of 9 to know the exact total bone surface area. You want to know the sites involved and then the depth. Then if there's bones to the face, you will look out for singeing of the nasal hair. When you see singeing of nasal hair, that's the nasal hair being burnt, looking dark and burnt, you would suspect inhalational injury. Then hoarseness of the voice, suspect inhalational injury as well. Then examine all other systems. And then investigations, other investigations not carried out previously are done now. So you can do a trauma series of X-ray if you suspect fractures. Then you can do a clotting profile. You can do total protein because nutrition of this patient is very, very much important. Then you can do urinalysis, you're looking at for myoglobinuria. You can do an electrocardiogram in case of electrical injury. You could do bronchoscopy, CT scan, MRI in case of inhalational injury. That's CT scan of the lungs, then of the chest, sorry. Then you can do an electroencephalogram in case of carbon monoxide poisoning. That is where you have these facilities anyway. Other treatment modalities include deep vein thrombosis prophylaxis, because they would have a long hospital stay in bed. There will be need to prevent deep vein thrombosis from occurring. So usually Clexane may be used, which is a low molecular weight heparin, and low doses are used for prophylaxis. Then antipyretic agents are also used because as the bone wound begins to heal, it gets itchy because of histamine that is released. Now, nutritional support is a very, very important aspect in managing bones patients. Now recall that in our video on surgical nutrition, we talked so much about nutritional that's the nutritional requirements in well-nourished patients and then in patients under stress. So I'm sure you'll be able to follow if you have seen that video. So recall that in a well-nourished patient, that's in an unstressed individual, the non-protein requirement is 20 to 25 non-protein requirement per kilogram per day, while the protein requirement is 1 gram per kg per day. So this is like the non-protein calorie requirement you need in a day, right? This is the protein requirement you need in a day. But in bones, these values increase, and the increment is really, really high. So you see, it increases from 20 to 25 to 40 to 45 non-protein calorie per kg per day. That is an amazing increase. While the protein requirement increases from 1 to 2 to 3 gram per kg per day. So to calculate the nutritional requirement of a patient with bones, there are several formulae. We have the Cureri formula, the Bonderland formula. Now we'll see the Cureri formula. And this is the Cureri formula, which is 25 kilocalorie per kilogram plus 40 kilocalorie per total bone surface area to get the calorie requirement for the patient. Now, I want you to remember, as we just said in the previous slide, that we said normally the non-protein calorie requirement in a normal individual is 20 to 25, but in bones it's increased to 40 to 45. So the increment is really large. So this formula now, it includes the maintenance, which is this 25 kilocalorie per kilogram as maintenance, and then this 40 that is seen in bones as the deficit. So the maintenance is 25 kilocalorie per kg, which is the normal maintenance in an unstressed condition, while this 40 kilocalories the calorie requirements in bones as the deficit. So when you calculate this, you get the calorie requirement for a patient with bones. I hope you understand this. Let's take an example. A 40-year-old man weighing 76 kg sustained mixed deep dermal and full thickness bones. Remember what deep dermal is, Abi? It's the bones that involves the reticular dermis. and then we have full thickness bones, the bones that involves the entire thickness of the epidermis and then the dermis. So with a total bone surface area of 40%. So this patient is 40-year-old, he weighs 76 kg, and the total bone surface area is 40%. Now calculate the nutritional requirement of this patient using the Curry formula. And this is the formula here. So this is the formula here. We already said what the formula is before. 25 kilocalorie per kg, which is the maintenance. And this maintenance is gotten from the normal calorie requirement and unstressed individual, plus this 40 kilocalorie per total bone surface area. So let's impute the weight and the total bone surface area. So if you input it, you have 25, which is here, 25 times 76, which is the weight of the patient, plus 40 is the constant, that is the requirement in bones, times 40, which is the total bone surface area. And then when you do the mathematics, you get 3,500 kilocalorie. So this is what this particular man will require, because we took into consideration his weight and his total bone surface area and inputted it into the Curry formula, and this is what we have for this man. So it means therefore this patient requires 3,500 kilocalorie of energy, and this will be gotten from the so to get the balanced diet. Now you have to get carbohydrates, fats. So you have to include the carbohydrates, fats, and protein in their various proportions. So you have to take into account the various proportions. The carbohydrates, protein, and fat, they have their various proportions to give a balanced diet. Carbohydrates usually roughly 60%, proteins roughly 25%, fat roughly 15%. So if we take 60% now of 3,500, it means we'll have 2,100 kilocalorie for carbohydrates. If we take 25% of 3,500, it means we'll have 875 kilocalorie of protein. If we take 15% of 3,500, it means we'll have 525 kilocalorie of fat. So it means if you want to give this patient food now, when you calculate the kilocalorie of carbohydrate you'll be given, it will be 2,100. Kilocalorie of protein you'll be given will be 875, while the kilocalorie of fat you'll be given will be 525 kilocalorie daily for this patient. So I think it's pretty easy to understand. So just know this Curry formula, and it's not difficult to remember. 25%, which is the maintenance, and 40, the increment from the unstressed condition to the stress condition is almost like times 2. It's almost times 2. So now this is the Bunderland formula. This formula, it's calculated separately for the calories and then for protein. So it's the previous formula we talked about, it included both the calories gotten from carbohydrate, fat, and protein together. But this formula separates that for carbohydrate and fat and protein separately. So you have to calculate the calorie requirement for carbohydrates and fat, and then for protein separately. And the formula is 30 kilocalorie per kilogram plus 70 kilocalorie per total bone surface area. And then for protein, you have 1 gram per kg plus 3 gram per total bone surface area. So you can just cram the Curry formula. You can just remember the Curry formula rather, and then you may just remember that there is a Bunderland formula, and then try to remember it if you can. So complications of burns. So you have early and late complications. The early complications include wound sepsis, renal shock, sepsis, chest infection, urinary tract infection. We already explained how these infections would come about. So you could have cardiac arrest from electrical injury. Then late complications have hypertrophic scar, keloids, wound contracture, actually following joints. When there's bones to joints, it could have during healing, it could have contractures, then Majorin's ulcer. When a bone wound refuses to heal, it can undergo malignal transformation and become Majorin's ulcer. Now, prevention of contractures. There's so many ways to prevent contractures, but I just give 3 in this presentation. Early skin cover. So for joints, you usually institute an early skin cover if there is bone over a joint. So if there is probably a deep dermal bone, you debride, remove the dead tissue, and then you would, as early as possible, want to do a skin grafting for that part, because you don't want it to just heal on its own. If it heal on its own, it's definitely going to undergo contracture. Then you splint joint in position of function. So you splint the joint, you mobilize that joint in position of function, and you institute joint exercise in full range during recovery. So when after recovery, you institute joint exercise. So in conclusion, the best way to treat bones is to prevent them. That's what my teacher told me. Early resuscitation is key in bones management to prevent collapse of the intravascular compartment, to prevent bone shock, and then to provide free water for metabolism. References: lecture notes by Dr. Agbonoga, lecture notes by Dr. Ernest Udefiagbo, and Baylis and Love textbook. So thank you so much for listening patiently. I know it was really a long one, and I hope you took 1 or 2 from this discussion. So thank you once again, and see you in our next surgery video.